Hello everybody. Today we're going to be talking about gallbladder pathology. We're going to start with cholelithasis. So what is cholelithasis? It's like I always try to explain to students, the first thing you want to do is to break out the word into pieces. Cholelithasis. Col means gallbladder. Lith means stone. So we just broke down the pathology. Gallbladder stones is a fancy name for cholelithasis. On the right side of the board here, I've drawn out the anatomy that I'm going to be using to describe every single pathology. And I want you to follow me here. This is a very easy topic. To be honest with you guys, you're going to see this multiple times in your career. People have gallbladder pathology. They're going to be coming to the ER almost, you're probably going to see once a day. This is the most common, problems you're probably going to see in the United States, anywhere in the world, right? Because it's just that common. But I want you to focus on this side of the board because I want to talk about the anatomy first, because everything we're going to be doing from now on is going to be based on this anatomy, okay? So that is the liver, right? And inside the liver, you've got hepatocytes, which you can see over here. That's the central vein I just put in the middle. And coming out of the liver, we're looking at the hepatic vein, which is eventually going to drain into the IVC. You following me? Coming out of the liver, which if you haven't watched the liver topic that I made, you have to go back and watch. You can click on the link below. Coming out of the liver is the biliary tree. The biliary ducts come all the way out of the liver, and now they're draining through sinusoids all the way out into the liver. And coming out into the biliary tree, you make this door entrance. And everything we're probably going to be talking about, I want you to focus on this doorway right here. Extremely important. That is called your cystic duct. Why? Because it's the duct that goes into the gallbladder. That's the cystic duct supplied by the cystic artery, especially the right one. And here is your gallbladder. That's why I put it in green, because bile is green. Those little black stuff I put in here are the stones. We call them cholelithasis, right? Gallbladder stones. Now, out of the gallbladder, we're going to be tracing it down, and we got the common bile duct. And from the common bile duct is going to come together. It's going to come together with the pancreatic duct to form something you guys all know about, called the sphincter of Oddi. That's what I drew right here, the sphincter of Oddi. And both the stuff all the stuff coming out of your pancreas, all those pancreatic enzymes, and also your bile are gonna flow and kind of drips into duodenum, and all this stuff are gonna be doing all the work to get what? Metabolism done, breaking down your food particles, fat, and all that good stuff, right? So, typical, how does the gallbladder work before I actually start? When we eat fatty food, pizza, everybody likes that, I know, right? Pizza, French fries, right? All this fatty oil, fried chicken, all these things has fats in them, right? Fats need lipases, but it also needs, before you can break fats and use it up, and before you actually digest and reabsorb fat, what do you need? We need CCK. So what's the first signal that happens? Once you eat and food is coming from your stomach, right? So this is going to be the pylorus, and bam, there goes the stomach, right? When food gets into the duodenum, it sends a signal. What do you want to do? We make cholecystokinin, right? CCK. That is the hormone that we make automatically, which does what? It causes the gallbladder to do this, to contract. When the gallbladder contracts, it spits it out. What does it spit out? It spits out bile. And the bile that comes through the common bile ducts, it goes into a duodenum, causes emulsification of fats. What does that fancy word mean? Emulsify. Think about it. Every time you go into the dishwasher, you try to wash your dishes, right? You take soap, you wash dishes, all of a sudden all the little dirt comes off your dishes. What do you think that's doing? That's called emulsifying agents. That's exactly what bile does. It breaks down all those all those big fat globby stuff. It breaks it into little micelles, right? We call them micelles. This is just basic physiology, so that by the time we are done talking about the pathology, everything should make sense, right? You make those little micelles, they taught you in college, right? Kind of goes around like that, so that, right? You get those nice little micelles that has the hydrophobic layer and all like the phospholipid membrane, and you get this tiny little droplets, and these droplets go into your what? It goes into your duodenum, goes to your jejunum, and then lipases can act on them, breaking fatty acids into what? Breaking like long chain fatty acids into what? Glycerol and shorter chain fatty acids, right? But that's just basic physiology. But the most important thing is to understand the anatomy that I just broke down, because everything we're going to be talking about is going to be focusing straight on this picture, okay? So now that we know what happens, how bile, actually, I forgot to tell you how bile is made. What is bile made out of? This is still basic physiology before I actually start. Bile is made out of cholesterol, right? Also, you can be making it out of what? Pigments from bilirubin. So, as you can remember from your basic physiology in medical school or pharmacy school, wherever school you go to, you have to realize that when red blood cells are broken down, they can form bilirubin and biliverdin, and all this thing can go down, shunted down through the liver, and when they get to the liver, they're processed, they're made into bile acids, right? These bile acids are also coming into the liver and go into your gallbladder. You also use cholesterol, right? All the cholesterol that your body doesn't need, it shunts it down into the gallbladder. So guess what? You can kind of like dump it out and poop it out if you don't need it, right? So that's how bile comes from. That's what bile is. But now let's talk about how you develop gallstones. One of the first things you have to realize is we have risk factors, right? Some people get gallstones, right? They get gallbladder stones all the time. You're going to see that they're going to come in it, right? So what's the first most important risk factor we want to talk about? Let's talk about what kind of stone it is first, right? So there's two types of stones. We have cholesterol stones and we have pigmented stones. So if we go down this pathway right here, cholesterol stones are made out of cholesterol, right? Funny enough. But what are the risk factors that predispose people to develop cholesterol stones? The first thing, obesity. Being fat. I told you multiple times, being fat is not cool. Well, it's not cool. You're just predisposed to a lot of things. Because you're fat, you what? You have a lot of fats, right? What do you think fats are made out of? They got those nice, beautiful, right? Fatty acids, right? And it prompts you to make what? You have a lot more cholesterol problems. So if you're obese, you may have cholesterol stones. What are the risk factors do you guys think can predispose you to have a lot of gallstones? Diabetes, right? People with type 2 diabetes, they're very big, they're chubby, right? They make a lot of fatty acids. They have a lot of, adipose tissue. Adipose tissue equals cholesterol. Cholesterol ends up what? Because they make so much, right? They make so much cholesterol, the cholesterol overrides and takes over. So, right, if I were to have fluids in here and I'm dumping a lot of cholesterol in there, eventually we're going to saturate these bile acids. They can't make it liquid anymore. They become hard as rock, right? Number 3, high cholesterol, right? If you have a lot of cholesterol, hyperlipidemia, you're prone to develop even what? Gallstone. What is the most common thing women do today? They don't want to get pregnant. What do they take? They take birth control pills, right? So if you're taking birth control pills has what? A lot of estrogen. This is gonna drive you crazy. I know. Let me show you something real quick. Estrogen is made out of this compound. I can't believe I'm drawing organic chemistry information on the board, but yes, I am. Because you know what? Everything makes sense. If you understand the whole picture, makes sense. This is cholesterol. It might not be the exact, but just kind of give you, it's got all this what? Benzene rings. They're hydrophilic, right? Hydrophobic, I'm sorry, right? They're not water loving. When you break all this estrogen coming from cholesterol, we're back to the what? We're back to see exactly where we started again. Estrogen, too much cholesterol, you form a lot of stones, right? How about something else? Well, they try not to get pregnant, they end to get pregnant. Oops. Next time, make sure you use the protection, right? But since they forgot to use protection, they became pregnant. Well, not cool, but it's cool if you're ready to get pregnant. Not cool when you get pregnant. Now, if you get pregnant, that's another risk factor. If you're pregnant, you have a lot of estrogen. Remember, you need to make big boobs. You need to have a lot of stuff for the baby. Estrogen is important for pregnancy and progesterone, right? Too much estrogen. What are we talking about? We're talking about the cholesterol pathway again, right? So what happens? If I have to draw this pathway, it's driving me crazy, but we're back to making to a lot of cholesterol. Okay? What are the risk factors are we looking at? Crohn's disease, right? That's another important risk factor. Cystic fibrosis. These are all different kind of risk factors that are associated with what? Developing gallstones. Now that I'm done with the cholesterol aspect of this lecture, let's talk about pigmented stones. I love pigmented stones. You know why? You don't get them often. And when you do, you probably figure out where they're coming from. Pigmented stones, right? They're pigment. They're colored. Cholesterol stones, they're yellow, green in color. Which, by the way, maybe since I try to make these videos more interactive. So, kind of yellow, green. However, pigmented stones are usually black. They're usually black stones. Where does pigmented stone come from? This is usually associated with what? Hemolysis. Hemolysis means what? Breakdown of red blood cells. So let's start to break down the red blood cell, right? So I've got a nice, beautiful red blood cell right here. Donut shape. When I break the red blood cell down, I break it down to what? Hemoglobin, right? Hemoglobin eventually is going to be broken down into biliverdin, which is broken down eventually into what? Bilirubin. So, what kind of patients are very susceptible to hemolysis? You know the answer. When I talk, you can watch all the videos in hematology, but right now, for pigmented stones, sickle cell. Sickle cell patients, they're always doing. You know the problem with sickle cell? That's a whole different video on its own. This is what their red blood cell looks like. It's sickled. If it's sickled, what happens? They're not strong. Every time they try to bend through your blood vessels, they break apart. They're very fragile, right? They go through the spleen. The spleen is like, oh, look at this little red blood cell. I don't like you. It splits it apart into pieces. Sorry, but hemolysis. What else can you also develop hemolysis from? How about this? Hereditary spherocytosis, right? These are topics we're going to just talk about in details. If you have spherocytes, if your red blood cells look like spheres, they're easy to break. They break into pieces, you go into hemolysis. Thalassemia, right? People that have thalassemia, it's either alpha thalassemia or beta thalassemia, right? If you're not making a lot of beta cells, the red blood cells are not really stable and solid, you break them into pieces, okay? Also, I got another nice one for you, which we're going to talk about in details when you watch other videos. I've got a young guy, actually not a young guy, a 59-year-old male, a 70-year-old male. I listen to his heart, I'm hearing like, duck, duck. locked up, locked up. But the locked up in the second heart sound right here in the second right intercostal space is very loud. I'm like, sir, I hear like a little murmur in your heart. What is that? It's like, oh, doc, I've got a heart valve. All of a sudden, I'm not surprised because if he's got a heart valve coming out of his aorta, every time red blood cells go into, they get shredded. You know what? These valves are not cute, especially the artificial. If they're metals, imagine, cute little red bloody. It's kind of like strolling down the street. He's trying to go out through the aorta, right? He goes through he has to go through metals, and the metal slams on his lap. Oops! Yanks him off. Funny enough, you got another red blood cell, trying to get his way out, gets cut. Bam! He get pinched in his butt. He get hemolyzed. We call that microangiopathic hemolytic anemia. But we're going to talk about that in hematology. This, right now, talk about gallstone. These are things that cause you to have hemolysis. Right? So, those are the two kind of stuff. I like medicine. When these are two, I just take them for two. Let me get the table for two, please. Now that we've understood where stones come from, right? What kind of stones we make. Now let's talk about pathology. These patients, remember, in these lectures, we've talked about the definition, we talked about the causes, history. When patients with gallstones come into the hospital, right? They will come in, they'll say, you ask them questions. How you doing, man? Doc, I've been having this pain right here in my room. They're not going to say right upper quadrant, right? You as the doctors, when they point to this area, you're like, that's the right upper quadrant. They said the pain, it comes on and off. Sometimes you ask them, is it when you eat an ice cream? Or when you eat some kind of like fatty food, fried chicken, french fries? They're like, yeah, doc, I had pizza last week. What happens? After I ate the pizza, I had this little pain. It lasted a few hours. Then it went away. I'm like, whew, thank God. You know what we call that in medicine? Biliary colic. Right? Biliary colic. Because biliary colic is physically, now, I want you to follow the picture. What had happened that they don't know is when they ate the french fries, right? The french fries was traveling. When it got in here, all of a sudden, CCK was given the notification to contract the gallbladder. However, a stone did this. I want you to watch that carefully. The stone got dislodged. The gallbladder contracts. The stone went out. Now the stone got caught by the door. I got a little story, right? So these stones were told, listen, mom said we should not leave the house. However, there's always that kid in the house that said, no, I'm not going to listen, right? But you know what? You got to pay a price for it. So what happens? One of the stone got dislodged as soon as mom left the house, got caught, and the cystic duct. Because when cystic now contracts against the stone, bam! The door kind of hits the stone in the head. I'm just giving you an analogy. It hurts. The patient's like, oh wow, the pain is very painful. It's very crampy. It lasts for a few hours. But then it goes away. You know why? Because then the gallbladder relaxes and the stone falls out. When the force falls back into the gallbladder, the pain doesn't come again. That is called biliary colic. It's a temporary obstruction of the cystic duct when CCK contracts. Now, aside from right upper quadrant pain, these patients, they might complain also for some nausea. But for the most part, it's just biliary colicky pain. Now, they might also tell you, doc, you ask them, does the pain go anywhere? They're like, yeah, it goes right to my shoulder, or it goes right over here around my scapula, or it can go right to my back, right? That's called radiation, referred pain, right? A right upper quadrant pain referring to scapular, you know what that sign is called? You're going to become a star today. Bohr sign. Okay? That is Bohr sign. Right upper quadrant pain going up to the scapula. Now, how do we make the diagnosis? Pretty easy. We have this very, very expensive equipment in the ER. Very expensive. It's like one of the biggest technology of the century. It's called an ultrasound, right? We grab an ultrasound, you check in their belly, you see stones, right? You see the stones casting a shadow, right? You see the stone actually casting a shadow right below over there. And that's the ultrasound machine. And that's where you see the stone. You're like, oh man, you've got a stone. They're like, oh yeah. Sometimes we do an MRI, sometimes we do a CT. But for the most part, how do we manage this patient? Remember, we've talked about the history of physical exam, right? Now, how do we manage them? There's really nothing you can do. It's a stone, right? It's symptomatic treatment. For the most part, it's just biliary colic pain. So you might tell them, watch how many, cut down on the fatty foods you're eating for now. If the stone is not bothering you so much, if the pain becomes constant, that is going to take us to the next lecture, which will be cholecystitis. Okay? So what I want you to realize is the summary of this video is pretty straightforward. We just talk about gallstones, which are made coming from the gallbladder. We've got two types. We've got cholesterol stones and we've got pigmented stones, right? We talk about the risk factors, history, right upper quadrant pain, going biliary colicky pain, right upper quadrant, going to the shoulder, which is Bohr sign, right? And that's the summary. And also diagnostic study, we do an ultrasound and how do we treat? It's symptomatic. If this pain gets worse, that will be the next lecture in this video. Thank you.